All right, in this video, we're going to address how to do a subcutaneous injection. For the sake of this video, or this skill, we have a physician's order of 1,000 units of heparin on the vial of the medication. We're going to pretend this is it. It says 10,000 units per 10 mLs. So if we were to do the math there, we're looking at 1 ml of this medication will be the equivalent of our 1,000 units that we need to administer for the patient. So I have acknowledged this medication order, I collected it, and we're going to head to the patient's room for administration. Upon arriving at the patient's room, knock before entering. And so I'm just gonna knock, hello, enter. My name is Michelle. I'm your nurse today. I have a medication here that the physician ordered. I just want to verify you are the correct patient. So if you wouldn't mind confirming your first and last name and your date of birth. And while you're doing that, I'd like to take a look at your ID band so I can just make sure everything matches up. Perfect. Everything does match up. So I'm gonna make sure we've got some privacy in the room, especially because I'm gonna have to, show a little skin in order to do this injection. So I'll close the curtains behind me. Gonna hop on the computer and just verify with the patient at the bedside right here their allergies and make sure that if this is a new medication, there isn't any other factors that would send a red flag as to why we shouldn't be administering it, just in case somehow it's something that the physician might have missed. We're gonna go over any contraindications for administering this medication once again, just in case somehow the physician, upon ordering it, made a mistake. Those contraindications would be if they already have excessive bleeding, if they've got ulcers or any other blood clotting issues already, which I would hope wouldn't be the case if this is ordered, because it would be highly contraindicated. So, we would address things like that, but then also kind of precautions that we would want to take for specific patients. If they're pregnant, we want to keep a close eye. It's not necessarily contraindicated as, warfarin or some other medications might be. But we would definitely, in that population of pregnancy, we want to keep a closer eye on them, make sure that they're doing well and, they're getting their labs done regularly and all of that. Other reasons that we wouldn't want to give it to somebody maybe, or we would be reluctant to do so, or be a little more, I would say, attentive after administration, would be if the patient is an alcoholic and, they are drunk at the moment. That would be absolutely terrible. But alcoholics, that thins your blood as it is. It would be contraindicated to give a medication to further, anticoagulate if they're already self-administering things like that are doing the same thing or help to exacerbate that response. So we wouldn't want to give it to somebody who has alcoholism. And I believe if you have severely high blood pressure, if you are a severely hypertensive patient and it's uncontrolled, especially, you definitely don't want to give it. And that is because they're already at risk for hemorrhaging. If we throw on top of that medication that will prevent them from being able to clot or clot as effectively, then that could be a very, very serious consequence if they did end up having like a hemorrhagic stroke or something. I don't know that there would be any saving that person at that point, because it would be incredibly difficult to stop the bleeding, one, and the amount of blood being lost would be so great and so quick. That would be a very serious one to stay away from. So moving on from that, those are kind of, depending on my patient. I wouldn't address all those things with everybody because It's not necessary. I would tailor the information to my patient and what they're currently, what their ailments are, or comorbidities, or whatever it is. So we go through that, and I would ask if there's any questions or concerns. If family is present, I'd make sure that they felt comfortable with it too. And so then we'd move on to inspecting the site for administration. I'm going to take a look. If it's like a normal sized person, everybody typically has a good little chunk here that you can grab. And so, even if it's not a whole lot, that's still enough. You just want some subcutaneous tissue. And if it really is a very skinny patient and they don't have a whole lot of extra fat to them, you can always, instead of going in at a 90-degree angle, go in at more of like a 45 and grab what you can. Just pick the site with the most fat, and that can be in various places. From the stomach, you only want to go about 2 inches away from the navel. You could do the back of the arm. You could do the kind of backside, lateral-ish thigh back there, because, we call it our saddlebags. Everybody knows what that is. Yep, you can do it there. But the site that is most preferred is to just do it on the abdominal tissue here. It's usually, the one and true. You don't want to keep on administering over the same spot, so make sure that it is switched up in between injections. So confide in your patient. They know their body best. Ask them where they'd prefer to have it. Where was it done last time? And make sure that you're going through all of that. And then, of course, you want to ensure that their labs indicate that it's safe to give them this medication. Take a look at their blood count. Look at the platelets. Make sure that everything is within a safe range to be able to give this medication and not cause your patient to bleed out. So we would have, at this point, had already gone through all of that to make sure that this is safe, and that is why I'm entering the patient's room with the medication. Okay, so moving on, as if I'm in the room here, we're going to now get ready to administer this medication. I am going to perform my hand hygiene and don my gloves. Sorry, now I gotta wait for this to dry. All right, I've got my supplies, everything at the bedside, and we're going to inspect the area. For my patient, we're just going to say that we're doing it on the abdomen here. We're going to grab a fold, and also we want to do that before even really getting, sorry, I'm jumping ahead of myself here. We're going to inspect. We want to take a look at the site and verify that there are no wounds, no sores, no bruising, inflammation, evident infection. You don't want to be putting an injection and causing more trauma to some area that already had trauma or, already is compromised. So be delicate with that process. We're going to inspect first and then palpate, because we don't want to manipulate anything before knowing what's going on first and actually seeing the body. So we're going to lift up, inspect the area, make sure that the abdomen is the spot that we want to go in, and it's safe and it's clean and skin integrity is there, and yada, yada, yada. So we move on to palpation. We're just going to make sure that we're also not going to inject directly onto any masses. So you're going to feel and palpate each quadrant just to make sure that there's not anything that you're really missing, and there's no tenderness, because you don't want to go into a spot that already hurts them and cause them more pain. And this would also be a good time if you hadn't, and the patient is typically sensitive to injections, or they just, a lot of people don't like injections. to help them feel a little bit more comfortable about the process, you can maybe 10 minutes before going into the room for doing the injection, bring them a bag of ice. Let them ice the spot and, you know, make it a little bit more comfortable for them. I'm sure they would appreciate it if they don't do well with injections in the first place. So after inspecting and palpating, everything looks good. So we're gonna go ahead with this abdominal injection right there. And while we have the little fold of fat, we want to ensure that the needle size is appropriate for that fold. So essentially what you want to do is make sure that the length of the needle is half the length of the fold. That's just your best rule of thumb. So with that in mind, I am going to stick with the needle that comes on the syringe because it's the shortest. Let's see here. Actually, let's see here. Oh, I like this. Here we go. I found a 22 gauge. We're gonna use that. Something a little bit smaller. It doesn't need to be a 20 or an 18. We'll save our little mannequin stomach over here. So I'm just prepping everything here. Getting it ready, not quite taking it out, but just opening so that in the moment I can just breeze right through all of this. Okay, so we have our little fold of fat. We're gonna pretend that I'm squeezing it. You can't really squeeze these very well. So I'm holding our little fat fold. My patient, we're gonna say, has a decent amount or enough subcutaneous tissue that I don't need to go at less than a 90-degree angle. So we've got our fat fold. I'm going to clean the area so it can dry a little bit before I do the injection. So I'm squeezing the little fat here. I am doing about 2-inch diameter, worked from the center outward, making sure that that injection site is going to be the cleanest spot on the stomach. And then I've got my medication here that I'm going to draw up. You want to be sure that you don't push the air. If it's like a pre-filled syringe of heparin, you're not pushing out that little air bubble. That is actually meant to be there, and so you don't want to push it up. So we're going to say we need 1 ml, so I am going to just do an air draw of 1 ml, and we're going to stick it in there. I'm gonna push that air in and let it draw up 1 ml. Okay. All right, so our site is all clean and I am holding it. We're going to just go in. Theoretically, I'm squeezing it, but I've got to hold it from the side so I don't slip in. We're just gonna go at a 90-degree angle. Gonna slowly push the medication in and slowly remove. I'm going to recap my needle, dispose of it in the appropriate reciprocal, which would be a sharps container, and either do just a little wipe with that alcohol swab or, or do a light dab with some gauze. It would be probably better to have mentioned beforehand that this might cause a little burning or stinging. I definitely forgot to do that in the moment, but you would want to do that beforehand, let them know what to expect. With the whole side effects part, that should have been included, not just the side effects later on, but in the moment of receiving the injection. It might sting, it might burn a little bit. And so with that there, we don't need to dress it at all. Just a light dab with this. Make sure that the patient knows not to massage the area, don't rub it. You just want to leave it alone and let the medication absorb as it does. After administering, cleaning up the site, taking care of all the supplies that we had used and disposing of it, not to leave a mess in the patient's room. Going to discard my gloves and perform hand hygiene again. I'll talk to the patient, address any other concerns or questions, and then before leaving, make sure that I give them a little extra education on precautions after administration and as they're using this medication, especially if this is going to be something that they use for long term. You want to advise them to be very careful about doing any crazy activities. If they are an adrenaline junkie, I know I am, be careful. If you break something, you fall, you get a cut, it is more serious now than it was in the past. So, switch to a soft bristled toothbrush. You don't want your gums bleeding profusely. I don't think people think that far into it. You just think you're getting this medication, it'll thin your butt a little bit, but no, you need to be more careful. You're going to bruise a lot easier, you're going to bleed a lot easier, so you just need to be a little bit more careful in your day-to-day activities and reel back the risks a little bit more. Another thing is with long-term use, you might need to up your calcium intake and make sure that you do a little bit more for your bone health, because long-term use is associated with osteoporosis, just because it's interfering with the normal activity of your osteoclasts and osteoblasts. So while you're still breaking it down, you're not rebuilding it, and your bones will just become more and more fragile throughout long-term use of heparin. Another thing is to make sure that any additional over-the-counter supplements are all gone through a process of, medication reconciliation with your physician, or at least the pharmacist. You're getting all your medications and doing everything through the same pharmacy, so that it makes it a little bit easier and more streamlined to be able to address and identify if there's going to be any drug-drug interactions. It's just always smart not to take anything new without consulting your physician or pharmacist before doing so. You don't want to take any additional NSAIDs, over-the-counter supplements, aspirin especially, things like that you want to steer away from while you're on this medication. So, the big things being addressed here, those are what I would want to leave with my patient before leaving their side, and just make sure that they know how to identify if something adverse is happening, and ensure that their family knows too, because if they're going to be sent home on this medication, they run the risk of hemorrhaging, and we want to make sure that they get treatment as quick as possible if one of these severe side effects do happen. And the way to prevent that is obviously education and knowledge. So I think that is about it. I would, make sure that my patient's comfortable in bed, come and check back on them in a little while, and just make sure that they're not having any reactions. Make sure that the call light is at bedside in case they do start to feel any weird feelings that aren't normal. That way, just at a click of a button, we could be there. And I would, just make sure they're comfortable, say bye, hand hygiene, and exit the room. That's everything.